pregnancy, and I'm also going to talk about sexually transmitted infections today. Whatever else might come up. Bleeding is the first topic. We talk about this particular week because we're talking about acute problems in labor and delivery and during pregnancy. And bleeding is a situation that is always problematic whenever it occurs during a pregnancy. It has a variety of consequences depending on when it occurs during the pregnancy. Sometimes those consequences mean that the pregnancy is lost, that there's a fetal death, or that there is what we call a miscarriage or a spontaneous abortion. So we're going to talk about a number of those different possibilities. And basically how we view them and what we might do about them as nurses. But bleeding is always something if we have a patient who calls to report on the phone or comes into an emergency room or a clinic or a physician's office and says, I've been doing bleeding or spotting and I'm X number of weeks. It is always something that we need to pay attention to, okay? Because there's volume concerns, there's perfusion concerns, there's oxygenation concerns, etc. So if you look at it by trimester, which we have up here, in the first and second trimester, the big problems that we deal with are things like spontaneous abortion, an ectopic pregnancy, what we call gestational trophoblastic disease, which we'll talk about, and then placenta previa. During the second and the third trimester, placenta previa and placenta abruptia are the big problems. So placenta previa is the one thing that kind of carries through the entire pregnancy. It occurs at implantation and then can become a problem at any point in time during the pregnancy. So we'll talk a little bit about that, but it's the one that spans the whole continuum. When we talk about abortion here, we're talking about a spontaneous abortion, or what people might call a miscarriage, in lay terms. And when you look at a GT-PAL, unless you have a very elaborate one, because some of them do differentiate, but usually what you'll see on a regular prenatal record is, just GT-PAL, right? And A stands for abortion. They may not differentiate what kind of abortion we're talking about. So some patients will have a history of spontaneous abortion, which we're going to discuss, and also a therapeutic abortion or a voluntary interruption of pregnancy, a termination. Some patients may just have had terminations. Some patients may have just had miscarriages. It's kind of important to know, to look in the prenatal record, or at least to differentiate what the patient's actual history is, because they're two very different things, and they can be experienced as very different things. And so I think it's important to be sensitive to that difference and try to find out about that with your patients. It may be that they're not interested in telling you, but there should be some documentation of whether or not they've had a termination of a pregnancy or a spontaneous abortion on their prenatal record. It's also important when you're asking about pregnancies to ask how many times have you ever been pregnant, because sometimes individuals won't count a pregnancy that they lost or a pregnancy that they terminated as a pregnancy. And so you need to be aware of that. So sometimes a patient might have been pregnant 3 times, but they're reporting to you that this is their first pregnancy, because it's their first pregnancy that they're going to carry to term and hope to or plan to deliver a baby. So just to be aware of sometimes disclosure issues and be sensitive to the difference. So a spontaneous abortion is a loss of pregnancy prior to the fetus being viable, okay? And the other definition of it is the second line, which is prior to 20 weeks and smaller than 500 grams. So that's kind of the clinical definition, okay? The problem with those definitions is that viability is kind of like a moving target, okay? And you can deliver a viable fetus that's smaller than 500 grams. You can't deliver a viable fetus that's less than 20 weeks. It's very, very difficult to deliver a viable fetus that's less than 23 weeks, although some places say they've done it. I'm kind of skeptical. I've been around the block a few times. I've never seen a baby less than 23 weeks that survived, personally. But, it could happen. I think the state of today's NICUs is pretty remarkable in terms of preterm babies that survive. but it's still real hard to high-tech replicate a womb, a uterus. So viability, and we'll talk about this when we talk about pretermers, is around 23 weeks, give or take a couple of days, okay? Prior to 20 weeks gestation, you're definitely not going to deliver a viable fetus. And smaller than 500 grams, there, like I said, there are some babies that are delivered that are viable past 23 weeks that are smaller than 500 grams. So that weight criteria, well, I want you to know it. Once you get into the viable territory, it doesn't really hold water. You've got some very severely compromised babies that are delivered. They're intrauterine growth restricted, but they're still alive, they're still viable, they're, you know, they're still mature enough to attempt to survive. So just some comments on those definitions. In terms of spontaneous abortion, the risk factors are listed, a lot of the risk factors are listed here. We know that risk increases with age, okay? We know that sexually transmitted infections can cause perhaps sepsis in the uterus that may cause the loss of a pregnancy. There are anomalies for the fetuses that make them not only non-viable, but sort of they're no longer able to develop appropriately, so they can't survive even in the uterus. So those congenital anomalies may cause a spontaneous abortion. Things like diabetes, particularly a mom who is diabetic prior to pregnancy, sometimes that will increase her risk quite significantly. Structural problems, like the one that's most common is probably incompetent cervix. It's a cervix that can't support a pregnancy. Okay, once the pregnancy gets to a certain weight, the cervix just goes whoop, like a trap door, and the pregnancy delivers. And that can be managed with basically sewing the cervix closed until the patient is term. But sometimes the reality is that it happens before you know that it's going to happen, and then the next pregnancy is when it's managed. So those kinds of structural problems can result in spontaneous abortion. Things like autoimmune disorders like lupus that are connective, that may affect the connective tissue, can affect the ability to carry a pregnancy. And then the big one down at the bottom here, these clotting disorders, those are typically inherited. However, they really, as we've come to find in the last probably decade or 12 years or so, they really do affect risk of spontaneous abortion. And they also increase risk of things like placenta abruptia. Because with clotting disorders and either non-clotting or too much clotting, you know, there can either be bleeding and pregnancy loss or clotting and lack of perfusion and fetal death. So there's a lot of things that can happen there. So that's becoming a more commonly looked at risk factor, and women who have a history of that now are being managed with anticoagulants during pregnancy to hopefully prevent that, particularly if they've had a history of spontaneous abortion. So please stop me if you got questions, because I'm going to keep plowing ahead, you know how so I will, so okay. Types of spontaneous abortions, threatened and inevitable, okay? A threatened spontaneous abortion is one that hasn't happened yet, but it looks like it's kind of going to maybe, okay? An inevitable abortion is one that is going to definitely happen. And what's the difference between the two of those? Well, a threatened abortion, and we've got some pictures, but a threatened abortion is a patient is cramping, okay? They may have some spotting. They may have some lower back pain. They may have some pelvic pressure. But they are not doing the things that make us think they are in true labor, okay? So what would be the things that we would see that would indicate to us that they are in true labor from way back in the labor lecture? Dilation of the cervix. The cervix is starting to change. What other things are going to happen in true labor, we hope? Okay, contractions are going to get stronger. It's not just going to be mild cramping. Eventually they're going to kind of, you know, start to be a little more uncomfortable. What else? Membranes would rupture, and what were you going to say to that? Membranes are going to rupture. So eventually probably membranes are going to rupture, okay? And you're also going to have eventually some kind of descent. So the fetus is going to begin to progress and move out of the uterus into the cervix and into the vagina, all right? So threatened becomes inevitable once we see those true labor signs. They start to dilate, they start to efface, they rupture their membranes, there begins to be descent, okay? The contents of the uterus begin to move out of the uterus, down and through the pelvis and into the vagina. So then an inevitable abortion is one where that's happened, and then we have a couple of different things that we can look at. So if we look at these pictures, which I know are extremely tiny on your handout, this would be what we call a threatened abortion, okay? We've got a situation where this patient's got some bleeding, okay? We can see that. So she's bleeding out the cervix, and she's going to have some vaginal bleeding, or there's going to be noticeable bleeding on her underwear or on a pad. But what you see up here is that the fetus is still up high in the uterus. There's still intact membranes here, okay, this white line. The placenta is still attached. Okay, so the fetus is still in the uterus, is still intact, is still healthy, presumably still has a beating heart, okay? And so what would you do to find that out if there's a heartbeat? You probably couldn't put them on the monitor because in most cases these uteruses are still down below the pubic symphysis, you know? Remember, like the pregnancy doesn't come up above the pubic symphysis till about how many weeks? You know? About the end of the first trimester, 13 weeks, you begin to feel it up there. So we really can't put them on a monitor, but they may do an ultrasound. Okay, they may do an ultrasound, and more likely they probably will to see if there's still a fetal heart and where the fetus is. In this situation right here, we have what we consider an inevitable abortion because we've got the cervix that's dilating and probably effacing some. We've got a lot more bleeding going on, okay? We have rupture of membranes. It looks like the placenta is probably started to separate. There's this gray area, whitish area is kind of the placenta, started to separate from the uterine wall, and we have the descent of the fetus, okay? So that's inevitable. This is an individual who's going to lose this particular pregnancy. Okay. In this slide, what we see is what we call an incomplete abortion. And with an incomplete abortion, what happens is that the contents of the uterus aren't entirely evacuated or passed by the body. Okay, so the fetus or the embryo, if it's way early, may be passed. But there still may be fragments of membrane there, there still may be fragments of placenta there, okay? And so what would this person be at risk for then, if they've still got stuff in their uterus? Hemorrhage and bleeding, right, okay? And so their uterus, we know as long as there's something still inside that uterus, what's that uterus not going to do? It's not going to contract, it's not going to start to involute, and as long as it's not contracting and it's just kind of boggy, you know, floppy, not contracted, then that patient's going to bleed, okay? So what do you think this person would need? They probably need a D&C, a dilation and curettage, or also, they may also do it as a vacuum aspiration, which is basically using a curette attached to a vacuum to evacuate the rest of the contents of the uterus. So that's probably an individual who's going to need to have some kind of operative procedure. Yeah.
Are there any risks with vacuum aspiration?
You know, there's a risk with every procedure that you undergo. I would say that the risk for vacuum aspiration is probably no greater than just a regular D&C. It's just a different method. You're always concerned about uterine puncture, perhaps, you know, if you, or damage to the uterine tissue that could cause more bleeding, perhaps, if they curette a little bit too deeply. So, but I wouldn't say that there is any greater risk.
Question.
Yes.
On the first image, it looks like you see the membrane still intact, right?
In this particular image right here? Uh-huh.
So where's the blood coming from?
Where is the blood coming from? Well, probably where the blood is coming from is from the behind the placenta. Okay, that's probably where the blood's coming from. Are we?
I'm trying to read that little thing.
Okay. Well, A says threatened, B says inevitable, C says incomplete, D says complete, and E says missed.
Yes.
So we're going to go through all of them. So probably the bleeding is coming from behind the placenta, and there may be an edge of a placenta that is separated from the uterine wall, okay? Because we have to remember that if we think about the bag, okay, it's placenta attached, and then sort of like the balloon of the bag grows out from the placenta and goes around. So the placenta's here against the uterine wall, and then the bag is against the uterine wall as well. So if the placenta's separating, then you're going to have bleeding outside of that amniotic sac. Okay? All right. D is what we call a complete abortion, and that is when all the contents of the uterus are passed. Okay? Lots of times patients do not conveniently lose a pregnancy in an office or in a hospital or in an ER or whatever. You know, it happens when they're on vacation or when they get up in the middle of the night because they feel like they're leaking some fluid and they go into the bathroom and it's on the toilet or in the shower, or, you know, it's not in some place where they conveniently have a nurse to take care of whatever comes out of the uterus. It's useful, and I'll say this about complete abortions, it's very useful if a patient passes some kind of products of conception or pregnancy at home or wherever, that they bring it into the healthcare provider's office or to the hospital, particularly if they're an individual who has had perhaps congenital problems with fetuses being lost because of congenital anomalies, if there's genetic issues, if they're an individual who is what we might call habitual in having continued spontaneous abortions, they've had more than 2, or someone who has repeat spontaneous abortions. Because what's going to happen to try to figure out what that problem is that they're going to want to look at the fetal tissue, and they're going to want to look at the placenta. So someone calling over the phone and saying, I think I'm having a miscarriage, etc., if they have bleeding, if they have clots, if they can't do it, if somebody's with them that can, or if they have to do it themselves, to just ask them to wrap it up in a towel and bring it in to the hospital. I know it probably sounds insensitive, but it's important in those kinds of situations that they be able to look at the tissue. So with a complete abortion, all of the tissue is there, you know, the fetus, the membranes, the placenta, etc. What we have here is what we call a missed abortion, and that's essentially, it kind of looks like the same picture as up here. That's an individual who doesn't even have bleeding or cramping. It's basically a situation where a patient goes into a physician's office, knows they're pregnant, had a positive test, they can't find a fetal heart. So for some reason, the embryo or the fetus has died inside the uterus. Yes, ma'am?
Is there any association that you know between Ehlers-Danlos syndrome and spontaneous abortion, or
Ehlers-Danlos syndrome?
Ehlers-Danlos,
It's the connective tissue joint issue disease.
yeah.
Affects knees and things like that. You find out.
Well, then, you know, the entire abdominal contents can come spilling out later.
Yeah.
But I'm just wondering if there's any kind of association that you know of.
I would have to look that up. I have no idea. It's
Some
not
acquaintances
identified.
had 2 spontaneous abortions.
Mhm.
And I know that this person has that condition,
Uh-huh.
but I'm not friendly enough with them to ask
Right.
about a connection. I was
Right.
just curious if there's
I don't know that it's a significant risk factor. You know, there may be other things going on, you know, but I don't know that it is. So this would be, again, a person who is not aware that the pregnancy has died, that there's been a loss of the pregnancy because the fetus has expired, and it could be for any number of reasons. This is also an individual who might need a DNC, or who might get a stimulant to help their cervix dilate and for them to contract so that they can pass the pregnancy on their own, okay? So that may be dealt with in a number of different ways. But those are sort of the different situations that you might see walking through the doorway, you know, if you work in an OB clinic or in even in an ER, because that's usually where patients start unless they have an OB that they call and say, come on into triage or whatever. So these are the things that you're going to be looking at. You're going to be looking at bleeding and cramping, lower back pain, pressure, all those things that we might think about as being indicative that labor's starting. The patient may or may not have an ultrasound. If it's really clear that they are in the process of losing the pregnancy, then they may not do an ultrasound. The physician may or midwife may do an exam, determine if there's anything in the uterus, and then decide to take action. Yeah.
I just have a quick question about the last slide.
Uh-huh.
So this might sound like a weird question, question, but would they go through and actually perform like an assessment on a stillborn and do like 0-0 for APGAR, or do they have like a different protocol for?
Not prior to viability,
Okay,
no.
so after 20 weeks, they would have to.
After viability, they would document an APGAR, yes, okay? And they may do an assessment, depending on if the reason for the stillbirth or the fetal demise is identified already, you know? It may be a complete surprise, so they may not. They may do an autopsy. I mean, that's all pretty circumstantial and situational depending on what and why, you know? I think we were talking about somebody in clinical this week and the distinction between a nuchal cord and a true knot in the cord. A nuchal cord is a cord wrapped around the neck, and a true knot in the cord is the cord tied in a knot. And babies who survive a cord tied in a knot are pretty, you know, darn miraculous, because not all babies do survive a knot in the cord, because the tighter the knot gets, you know, that cuts off the blood flow from the placenta to the fetus, etc. So you could have a fetal demise. That's a pretty obvious cause for a fetal demise, but sometimes it's something else, you know. So, so after viability, yeah, they're going to do that. They're going to do that, not prior to. If the patient, is that a hand or is that a stretch?
It's a hand.
Okay, what's a hand?
After the missed abortion, you mentioned that individuals may need a D&C, and you mentioned another thing.
Sometimes patients will get medication to help just stimulate and soften up their cervix, like Cervidil. Some of you guys have probably seen Cervidil, and Professor Van Meter will probably talk about it next week. Used in labor and delivery. It can either be given PO or it can be given as a vaginal suppository. And it basically softens the cervix and basically stimulates contractions to occur, and that may be all that's needed for this particular situation, you know. And again, it would depend on the circumstances, how far along the pregnancy is, the woman, etc. Okay. Certainly as you get further out, closer to 20 weeks, you're going to be less likely to have a D&C and more likely to have labor stimulated so that the pregnancy is just passed naturally. Okay. But we did say some patients may have a D&C or a vacuum aspiration, so then of course they'd need informed consent, and you'd need to find out when the last time that they ate was. Usually these patients are given a little bit of sedation so that they're not awake during the procedure. After an abortion, if they have had a D&C or a vacuum aspiration, they're going to need some post-anesthesia care until they're alert, oriented, aware of what's going on, all the meds have worn off. They're going to be evaluated for post-spontaneous abortion bleeding, and they are going to have to be counseled and taught that they're going to have bleeding for a period of time after the loss of the pregnancy. It's going to be lochia, but it's not going to be as copious as we see at a term pregnancy, obviously. But they are going to have some bleeding. They're going to need to wear pads. They may have cramping. They may be given a prescription for something. They may just be told to use Tylenol or to use Motrin or ibuprofen. They need to return to their healthcare provider, and that's something that we're going to need to emphasize, because you really do want the woman to abstain from anything in the vagina until you know that the cervix is closed, all right, and the bleeding has stopped. Because if the cervix is open and there's still bleeding going on, what is she at risk for? She's at great risk for infection, which we would not want to have happen. So basically no sexual activity, nothing by vagina for at least 2 weeks until she's seen the healthcare provider. We know that the uterus is back where it belongs. It's kind of back to its pre-pregnant size and position. The other parts of this are, and this holds for any pregnancy loss that we're talking about here, because this is not the only situation we're talking about where there's pregnancy loss, is that we have to remember that this patient may need some supportive resources. They may not want them, but it's good to know what they are in case they do. MIS stands for Miscarriage, Infant Death, and Stillbirth. It's a national organization that does provide support, information, and run support groups for women, partners, families, etc., who have lost a baby or a fetus, either a miscarriage, an infant death, which would be, you know, up to a year, or a stillbirth, which would be after viability. Lots of hospitals run their own support groups. I know Holy Cross has a couple of the, because they're run by Trinity Health, but they have Sisters of the Holy Cross there. Actually, there's a couple of sisters who run a support group for fetal and infant loss. I think that probably most of the folks that they get are folks from the NICU, but they welcome anybody. So there's services like that in most institutions that do a fairly large business in reproductive health and in babies. I think the other thing we have to remember that this for a parent may be the loss of a child in the future, and it may be the loss of a fetus that they worked very hard to get pregnant with. I mean, some of these losses are individuals who have struggled with infertility for quite a while. Regardless of how the baby came to be, it's still somebody who they knew a birthday for, and they may have told a lot of people about it, and they may have siblings, etc. So I think we have to be really, really respectful of these losses and treat them with dignity and treat them with a good amount of allowing the person to grieve and to mourn the loss as they need to. Okay. And sometimes and the reason I'm saying that is because sometimes that doesn't happen. You know, when you say to someone, oh, you'll always get pregnant again, you don't know that. They may have spent $30,000 to have that pregnancy. So, you know, you need to be very careful about what you say in these situations. Now, an ectopic pregnancy, another loss. This is always the loss of a pregnancy. So this is a very cheerful session today. Looking at ectopic, and I was being sarcastic, looking at ectopic pregnancy, we're looking here and we see, you know, some risk factors that we might see when a patient who has an ectopic comes into our care. And lots of times women who have ectopic pregnancies may present in an emergency room because they have developed acute pain typically, and they've developed some bleeding, and it's like, well, what am I going to do? Well, let's go to the ER and figure this out. Some risk factors for ectopic are IUD use and sexually transmitted infections, and we'll talk about that. That'll make more sense when we talk about STIs. They're usually going to have unilateral pain in their lower quadrant, although if their ectopic has ruptured, they may start to have deferred pain to their shoulder because now they're doing a lot of bleeding into their belly. They typically have had a positive pregnancy test because usually ectopics don't start to become problematic until about the 8th or 9th week of pregnancy when they get to be a certain size. And they typically will have vaginal spotting or bleeding. How much bleeding is going on depends on how much bleeding is going on in the belly, basically. So if the ectopic has ruptured, then there's going to be a lot more bleeding. If it's just starting to cause some discomfort, there's going to be less. What happens with an ectopic, we'll look at a picture in just a minute, but basically we have a pregnancy where the egg's been fertilized. It just doesn't go where it's supposed to, all right? Normally when an egg is fertilized, where is it supposed to implant? In the uterus, usually in the upper segment of it, in the fundus, okay, hopefully. But with an ectopic pregnancy, that's not what happens. And the consequences of an ectopic are always going to be loss of the pregnancy. The other consequence potentially is if there's a rupture of an ectopic, that the woman is going to lose a fallopian tube, all right? And if there's a ruptured ectopic and she bleeds and bleeds and bleeds and she doesn't get to health care in time, then there is also potentially the loss of her uterus and or her life. Because if she bleeds out into her belly, then by the time she gets to health care, there may not be anything we can do for her. Certainly that's less risk here where we have a hospital like every few miles, but it's certainly a problem in places where health care is not particularly accessible and you'd have to drive a very long way to get to someone who can help you stop the bleeding. So this is what we're seeing when we're seeing an ectopic, okay? We know that basically with conception what happens is that we've got our sperm that are coming up here. This is our pretend vagina right here, and the sperm are traveling up here, you know, and it's a big race trying to get to the egg, and we have our ovary over here, and it's released an egg, and these little fimbriated ends here at the end of the fallopian tube are like waving the egg into the tube, like come on, come on, come on, you know, and somewhere sperm and egg meet right around in here, okay? And conception occurs, and then the conceptus, which starts to replicate, cells start to divide, and it's going da-da-da-da-da, it's dividing, and as it's doing that, it's just kind of tumbling down the fallopian tube, and it just lands into the uterus, and it finds a nice little piece of property somewhere up here in the fundus, and it implants, and that's how things should go. But sometimes it doesn't work quite that well. So in a situation like an ectopic, what happens is that the egg is fertilized, but it goes someplace else. And so in 99, well, maybe not 99, maybe in 95% of the cases, it's going to end up in the fallopian tube, typically in the ampular area, but sometimes in the isthmus. But sometimes it travels out and it attaches to the ovary or attaches to the wall of the uterus. It attaches to the abdomen, attaches to the abdominal wall, attaches to the bowel, floats down and attaches to the cervix. I mean, it can go anywhere at once, okay? It's not going to survive in any of those places. I would say the only time when an ectopic may go, and this is extremely rare, so please don't worry about seeing it, sometimes when it attaches to the abdominal wall, the pregnancy survives, okay? And sometimes they don't identify that it's in the abdominal wall if the woman never has an ultrasound until they're trying to deliver her, okay? So that would be the very rare case when an ectopic might, go further than it typically does. As I said, risk factors, things like pelvic inflammatory disease, and we'll talk about that in a little bit, STIs, history of previous ectopic, mom being an older mom, failure of a tubal ligation. Let's say that the tubes are cut, but they're not quite cut all the way, so they're patent enough so that a sperm can get up, but they're not patent enough that a conceptus can travel down, so it gets stuck in the tube. Endometriosis, Professor Van Meter will talk about that in a few weeks, but basically when the endometrial lining that you would see developing during the menstrual cycle and that gets sloughed off during a woman's menstrual period, if that decides not to stay in the uterus and it travels elsewhere, and it travels out the fallopian tube and attaches itself to the bowel, to the tubes, to the ovaries, etc., that can cause issues because that endometrial tissue can cause scarring. And if it causes scarring and inflammation of the tubes, then they become less patent. And so then they're not able to allow something to progress down into the uterus to have implantation. And then IUD use is just attached back up here to PID and to STIs. So we'll talk about that in a second. So as I said, with a woman who has an ectopic, she's going to have a positive pregnancy test. Yes, ma'am.
Does the IUD, does it cause scarring of the tissue and it sort of ruins the opportunity?
It increases your risk of infection if you are exposed to infections, and that can lead to pelvic inflammatory disease. Okay. So it's an associated kind of thing. Okay. These women are going to have a positive pregnancy test. They're going to usually have one-sided pain, and as I said, they may have spotting and vaginal bleeding. That's as long as the pregnancy is still in the tube, okay? What happens with tubal rupture is that basically the tube just cannot stretch anymore to hold this developing pregnancy. Because you think about how little the tube is, it's not big. I mean, it's smaller than a pencil. And now we have this conceptus that's stretching its boundaries, and eventually it's going to rupture. And when it ruptures, everything's going to start to bleed. So with tubal rupture, we see things like a great deal of vaginal bleeding potentially. We see severe abdominal pain. Now she's bleeding into her belly. We're going to see that referred pain to her neck and her shoulder that you often have when you have abdominal bleeding. Eventually she's going to lose volume. She's going to become hypovolemic. She's going to go into shock. Certainly she's already lost the pregnancy, so we don't want to compound anything by, her potentially losing all of her fertility or her life. So this is going to be a situation that can vary from, we can address this with medication, to she's going into the OR and we're cleaning out her belly and we're evacuating a lot of blood and we're going to see what's left. So it can go this broad spectrum of events. It may be confirmed by ultrasound, okay? And she may have surgery, particularly if the tube is ruptured. And what they'll do is they'll try to clean up everything. evacuate the clots in the blood, see if they can salvage the tube, which is highly unlikely, remove it, and then see what shape the uterus and the ovary are in. If she is identified as having an ectopic before it ruptures, then they can do one of two things. They can remove the pregnancy from the tube into the fallopian tube, kind of like, if here's the tube, okay, and it's patent, and here's the, fimbriated ends, and here's the pregnancy, then they can go in through a laparoscope, and you guys can't see this, they can just go in basically and just remove and suction the pregnancy out of the end of the fallopian tube, okay? So that keeps her tube intact. So she doesn't lose her fertility, on that side. She's, because once you lose a tube, you kind of lose 50% of your chances. So they may do that. The other thing that they often do is they'll give methotrexate, and that's another possibility. Because methotrexate is a chemo drug, right? And it kills rapidly dividing cells. And at this point, the embryo is a set of rapidly dividing cells. So essentially, the embryo dies, and the tissue is just sloughed off, either out the end of the fallopian tube or down through the uterus, and it's just reabsorbed. And that's probably the optimal way to manage it if they can, because they're not giving a large enough dose of methotrexate to cause any other kinds of symptoms. There's no hair loss, there's no sores, there's no, anything that you would think of with that kind of chemotherapy medication. So it's the most non-invasive way to manage this. Yeah.
How does that affect later fertility?
It does not affect later fertility. I mean, in that it is not it does not compromise later fertility, okay? It basically allows the tubes to stay intact, and why she had the ectopic in the first place, we may be able to identify a risk factor, we may not, but if she has risk factors for ectopics, that's not to say she won't have another one, but at least this way, the tubes are still, patent as they could be and healthy, so. So again, an ectopic can be an emergency situation. It can be a situation that's simply identified on an ultrasound, the first or second visit when a patient goes to see her healthcare provider, and addressed very simply. So you're going to see it in a variety of situations, okay? And its presentation is going to vary. Right? But it is, as I said, that's always going to be a pregnancy loss.